Welcome to the 2020 Statewide Provider Training for the Utah Department of Health, Division of Medicaid and Health Financing. On the agenda today, we will go over the PRISM project, provider enrollment, Medicaid, which will include our plans, the benefits, claims, billing, and hearings, followed by prior authorization, pharmacy benefits, and then we'll end with the Utah Office of Inspector General. So the Division of Medicaid and Health Financing, the Department of Health, is designated by the Centers for Medicare and Medicaid Services, also known as CMS, as a single state agency to administer and supervise their administration of the state's Medicaid program. The Division of Medicaid and Health Financing within the department is responsible for implementing, organizing, and maintaining the Medicaid program and the Children's Health Insurance Program, also known as CHIP. Within that division, we have 6 bureaus. They are the Medicaid Operations, the Managed Healthcare, Healthcare Policy and Authorization, Long-Term Services and Support, Eligibility Policy, and Financial Services. And with that, I'll turn the time over to Bridget Convey with our Utah PRISM project. Bridget?
Thank you, Cindy. My name is Bridget Convey, and I am a change management specialist with the Director's Office at the Utah Department of Health. And let's go to the next slide. There you go. The Provider Reimbursement Information System for Medicaid, which will be referred to by the acronym of PRISM throughout the presentation, is a multi-year project. It's currently scheduled to continue through the year 2022. PRISM will be replacing the Utah Medicaid Management Information System, which is also known as MMIS. Utah Medicaid started using PRISM with the implementation of the provider enrollment web-based system in July of 2016. And then in June of 2020, we implemented system changes in PRISM. Next slide, please. Thank you. Since providers started using PRISM in 2016, over 10,000 new providers have been enrolled. Since 2016, PRISM has been handling modifications of provider information, revalidation or recredentialing of enrollment, and applications for meaningful use incentive payments. The most recent changes to PRISM occurred on June 29th of this year, and we modified the login process, the re-enrollment process, updated enrollment types and steps, and included an auto-generated reminder and closure notice to providers, which included revalidation and license expiration. We do have a listing of FAQs or frequently asked questions that can be found at medicaid.utah.gov/PRISM-FAQ. Prior to the most recent implementation in June, providers were sent a letter that included instructions for accessing PRISM, validating enrollment information, and how to make necessary changes. Claims will continue to be paid out of MMIS until the beginning of 2022. With the most recent implementation changes, we made efforts to communicate with all stakeholders through the Medicaid Information Bulletin, also known as the MIB, and through the PRISM website, which can be found at medicaid.utah.gov/PRISM. We also have an extensive training library available for your review. And what I like about it is that all of the courses provide step-by-step instructions. And what I like the most is that you can pick and choose the topic that you might need help with. They're mostly shorter types of trainings that cover a specific topic, so you don't have to dig too deep for the help you're looking for. The e-learning modules are located at medicaid.utah.gov/PRISM-provider-training. And then the FAQs are at the site we discussed on the previous slide. We have a much larger implementation related to PRISM currently scheduled for early 2022. The major changes include managed care processes, prior authorization, member eligibility, claims adjudication, and claims payments. Later in 2022, we can expect the implementation of the member web portal and the audit studio, which is the fraud and abuse system. So with that, I'm going to go ahead and turn the presentation back over to Cindy. Thanks, guys.
Thank you, Bridget. All right, and we have with us one of our seasoned customer service unit employees, and I will turn the time over to her and let her introduce herself a little bit further.
Thank you, Cindy. Hello, thank you so much for being here with us today. My name is Tiffany Scouten. I work as a claims examiner in our customer service unit. Today, I'm going to be starting with provider enrollment. For new enrollment, the updated version of PRISM went live June 29th, 2020. You will need to have the NPI, Social Security number, or Federal Employee Identification number, date of birth, licenses, and ownership information ready for each new application. An application can be started by visiting our website, medicaid.utah.gov. Click on the Healthcare Providers box. Click on the first link titled Become a Medicaid Provider. A Utah ID will be required to start a new application. To obtain a Utah ID, visit login.utah.gov. Next, you'll want to choose the enrollment type that is appropriate for the provider. If your NPI is for an individual, please be sure to select individual or sole proprietor. Group practice and facility agency organization will need a group NPI with a tax ID number to enroll. A page will appear asking for the name of the provider, tax ID, provider requested effective date, etc. All fields marked with an asterisk need to be completed. Always maximize the windows that pop up. An individual sole proprietor will need to choose an applicant type. If billing as part of a group, choose rendering servicing only. If billing with your own tax ID without a group, choose individual sole proprietor. If the provider will only be writing prescriptions and referring, choose ordering, referring, and prescribing. Unlicensed mental health providers that are supervised, choose student and unlicensed providers. Providers that will only be billing Medicare crossover claims will choose QMB only. Enter the address on line 1 and then enter the zip code. Click the Validate Address button. Once all the information is entered, press the Finish button. Enrollment types, individual, group, facility, agency, organization in the lower right corner of the screen. Use FAO if you are an IHS facility. Complete all required steps. The billing providers step is optional. If your provider practices as part of a group, you will need to add the group NPI to the billing providers step. Every new application will need a provider agreement and provider user access agreement. The forms can be obtained here on our website, medicaid.utah.gov/Utah-Medicaid-forms. If the application is not submitted within 60 days of the date it was started, it will be purged from the system. And at this point, the provider will need to start over again. Revalidating. All providers are required to revalidate every 3 to 5 years, depending on their risk level with CMS. Utah follows CMS guidelines for revalidation. Revalidation is done through the PRISM system. Letters will be generated 90 days prior to revalidation cycle date. Providers can view their revalidation cycle on the basic information screen. Retroactive enrollment. Providers enrolling in Utah Medicaid will receive the date their application is correctly and completely submitted as their effective date. A backdate can be requested for extenuating circumstances. As part of the enrollment checklist, you can request a retroactive enrollment date. You will also be required to submit the request to providerenroll@utah.gov. The email must include the requested begin date, provider's NPI, and a detailed justification of why the request is needed. PRISM troubleshooting. A question you might have: I need to update my EDI and provider information. How do I log into PRISM? The answer: if the provider validated in the earlier version of PRISM, a validation letter is not required. If the provider did not validate in the earlier version of PRISM, a one-time validation letter is required to log into PRISM. You can request a copy of the one-time validation letter by emailing providerenroll@utah.gov or calling 1-800-662-9651. Press option 3 and then option 4. In order to complete the validation process, all steps that are marked as required and optional inside the business process wizard need to be updated. Another question you may have, I can't get the upload document step to complete. What am I missing? The answer, all new validations require a provider agreement and provider user access agreement. You can find a list of the required documents that need to be uploaded. Click on the Required Credentials button within the Upload Documents step. At the top of the page, there is a Required Credential button. Click the button to see what is required. Step 4, Provider Controlling Interest Ownership Details. You will be required to define the relationship between each owner or owners and managing employee or employees, excluding corporations. If relationships are not set, an error message will show up under Step Remark on the BPW page. To add a relationship, click on Step 4, Provider Controlling Interest Ownership Details. If the owner or owners, managing employee or employees are not related, please choose none. All owners and managing employees will be required to complete the final adverse legal actions convictions disclosure. The link is located at the bottom of each user's entry. This must be updated anytime a change is made to the ownership page. Every time that you make any kind of change, please click that link. Otherwise, your work will not be saved and you will need to start over. Multiple bank accounts, multiple locations. If a facility has multiple locations under the same NPI and need to split payments between 2 or more bank accounts, they will need to submit a separate enrollment with a different NPI. And with that, I will give it back to Cindy.
Thank you, Tiffany. All right, we'll go ahead and get started with our Medicaid presentation. So with our traditional Medicaid, the benefits under that are for members that are eligible for traditional Medicaid are children from the ages of 0 to 18, foster care and subsidized adoption, which includes all ages, members who are pregnant, aged adults 65 and older, blind or disabled, all ages, and members eligible under the cancer program. So the non-traditional Medicaid benefits, those benefits are eligible for members who are adults on family Medicaid programs with dependent children, adult caretaker relatives on family Medicaid, and adults with dependent children on adult expansion Medicaid with the ages 21 to 64. So we also have what's known as the Targeted Adult Medicaid, also known as TAM. So on November 1st of 2017, CMS approved the program to provide Medicaid coverage for adults without dependent children earning up to the 5% of the FPL who meet one of the three criteria below. So they can be chronically homeless, and that is defined as an individual who has a substance use disorder, serious mental illness, a developmental disability, post-traumatic stress disorder, or chronic illness or disability who has been homeless for at least 12 months, or on at least 4 different occasions totaling at least 12 months in the last 3 years, or has been homeless for 6 months within a 12-month period, or is a victim of domestic violence and is homeless, or is currently living in supportive housing and has met one of the above. The second criteria is those who are involved in the justice system and in need of substance use disorder or mental health treatment. And they're defined as an individual who is involved in a drug or mental health court, or is court-ordered to receive substance abuse or mental health treatment through a district or tribal court, or has complied with substantially completing a substance use disorder treatment program while incarcerated, or was discharged from the state hospital and was admitted to a civil unit in connection with a criminal charge, or is on probation or parole with a serious mental illness or substance use disorder. And the third criteria is an individual in need of a substance use disorder or mental health treatment defined as someone who is discharged from the state hospital due to a civil commitment or is currently receiving general assistance from DWS and has been diagnosed with a substance use or serious mental health disorder. So under the TAM, they do have dental benefits, and those dental services are available to eligible TAM members who are actively receiving treatment in a substance abuse treatment program. The TAM clients are ages 19 through 20. They're eligible for EPSA dental benefits regardless of the SUD treatment status as of January 1st of 2020. Services include porcelain and porcelain metal dental crowns, and all services must be received through the University of Utah School of Dentistry Network. Program coverage and limitations are found in the Utah Administrative Rule R414-49, in the provider manual under the dental, and then can also be found in the Medicaid Coverage and Reimbursement Code lookup tool. So the blind and disabled dental benefits, those services are available to adults who are eligible for Medicaid due to a disability or visual impairment. These members may be enrolled in a dental plan and may choose to receive their dental benefits through their dental plan or through the University of Utah School of Dentistry Network. Blind and disabled members who are 65 years or older are eligible to receive porcelain and porcelain to metal dental crowns only through the U of U School of Dentistry and their statewide network of contracted dentists. Again, program coverage and limitations can be found in the administrative rule, as well as the provider manual and the coverage and reimbursement lookup tool. Age dental benefits, those dental services are available to Medicaid eligible individuals age 65 and over. Services include porcelain and porcelain to metal dental crowns. The services must be received through the University of Utah School of Dentistry Network. Again, program coverage and limitations are found in the administrative rule, our provider manual, and the Utah Medicaid Coverage and Reimbursement Code lookup tool. Managed care. So our managed care is a healthcare delivery system organized to manage cost, utilization, and quality. Medicaid and CHIP managed care provides for the delivery of health benefits and additional services through contracted arrangements between the Department of Health and managed care entities, also known as MCEs. So under the Medicaid managed care programs, they include ACOs, UMIC, which is our new program that became effective January 1st of 2020, and that is the Utah Medicaid Integrated Care, which covers physical and behavioral health. Our home, which is our healthy outcomes of medical excellence, which covers physical and behavioral health. Our dental, and the PMHP, which is our prepaid mental health plans, which covers behavioral health. Under the CHIP managed care program, there is the MCO, which is the managed care organization that covers physical as well as behavioral health, and dental under the CHIP managed care program. So the ACO county updates, effective January 1st, Steward Health Choice Medicaid ACO became available statewide to all voluntary and mandatory enrollment counties. With this change, each of the 4 ACO plans is an option in every county in the state of Utah. As a reminder, Medicaid members living in voluntary counties have the option to choose an available ACO health plan or use the fee-for-service network, while those living in a mandatory county must choose an ACO health plan or they will be assigned to one. And we will be including a slide on the next slide that has the ACO plan chart by county and the effective January 1st, 2020. As you can see, this is our ACO county update plan chart. We also are including the managed care entity contact information in the slides, as well as our PMHP contact information in the areas that they cover. Effective November 1st of 2020, Optum will be the mental health and substance use disorder provider in Tooele County, and you will definitely want to look out for the October MIB or the Medicaid Information Bulletin for additional information on that. So Medicaid expansion. On December 23rd, 2019, CMS authorized Utah Department of Health to implement full Medicaid expansion. Full Medicaid expansion was implemented on January 1st, 2020. This expansion extends Medicaid eligibility to parents and adults without dependent children earning up to the 138% FPL, which is approximately $17,608 annual income for an individual, or $36,156 for a family of 4. Up to 120,000 Utah residents may become eligible for the expansion program, and individuals may submit their applications to the DWS to enroll in the Adult Expansion Medicaid program at the following website, medicaid.utah.gov/apply-Medicaid. And just for information, submitting an application for benefits does not guarantee coverage. The Medicaid expansion benefits. Under the Medicaid expansion, adults with dependent children receive the non-traditional Medicaid benefit package, and adults without dependent children receive the traditional Medicaid benefit package. Effective January 1st of 2020, the Utah Medicaid Integrated Care, also known as the UMIC program, started managing physical and behavioral health benefits through the integrated managed care plans for individuals living in 5 counties. These counties are Davis, Salt Lake, Utah, Washington, and Weber. Individuals living in other mandatory counties continue to enroll in one of 4 managed care plans for their physical health services and are enrolled in a prepaid mental health plan for their behavioral health services. Individuals living in non-mandatory counties may choose a managed care plan or may choose fee-for-service. They will also be enrolled in a prepaid mental health plan for their behavioral services. So the hierarchy governing Medicaid policy. The CFR is the Code of Federal Regulations, is a regulation established under the authority of the Social Security Act, 42 USC 1302, which directs states to maintain a written agreement describing the nature and scope of its Medicaid program and giving assurance that it will be administered in conformity with federal laws and regulations. The state plan is the Utah State Plan. It is a written agreement between the state of Utah and the federal government about how Utah will operate its Medicaid program. And then the rule, you'll hear us talk about the rule. This is the Utah Administrative Code or rule that is a legally binding policy defined, implemented, and overseen by the agency responsible. Manuals, these are the Medicaid provider manuals. They're used to describe service coverage and limitations in greater detail to provide guidance for delivering services to Medicaid members. Our lookup tool, this is the coverage and reimbursement lookup tool, which provides coverage definitions and limitations for specific medical and pharmacy codes. Forms, these are Medicaid documents authorized for specific processes and service authorizations, which also contain additional guidance on Medicaid requirements. MIBs are the Medicaid Information Bulletin. It is released quarterly to enrolled Medicaid providers to inform of policy and program updates. The Medicaid Provider Manuals and Administrative Rules. The Bureau of Healthcare Policy and Authorization, or BHPA, medical policy team continues to make changes to their designated provider manuals throughout the year. Provider manuals contain coverage policy and instructional information. Any changes or updates to the provider manuals are detailed in the quarterly publication of the Medicaid Information Bulletin, or as we refer to them as the MIB. Coverage policy is also located in the administrative rule R414, healthcare, and then healthcare financing, coverage, and reimbursement policy. And any changes to Utah administrative rules are detailed in the Utah State Bulletin as they go through the rulemaking process. So our Medicaid provider manuals, these manuals and attachments may be found under the administration tab under publications on the Medicaid website. These manuals, provider manuals, contain coverage policy for the fee-for-service Medicaid program. Providers are encouraged to become familiar with the updated manuals, noting changes in the structure, formatting, and content of the manuals. Attachments to the manuals are located within the list of provider manuals titled All Provider General Attachments. So to get to our provider manuals, we go to our website located at medicaid.utah.gov. You can click on providers and then click on the link that is shown, provider resources and information. Click on the manuals link. Again, click on the circled Utah Medicaid Provider Manual link. Click on Provider Manuals. And you can look and see that this is the Utah official publications page. We have a ton of really good information on this page for all of our manuals. To get to our general attachments, you'll click on the provider general attachment link. And again, there's a lot of information located in this link for our general attachments. So our coverage and reimbursement code lookup. So specific coverage policy for CPT or HCPCS codes is found in the Utah Medicaid coverage and reimbursement code lookup. The coverage and reimbursement code lookup allows providers to search for coverage and reimbursement information by procedure code, data service, and provider type. Providers may also download various fee schedules by plan type, provider pricing file, HCPCS and NDC crosswalk, and revenue code by plan type. To get to our lookup tool, you'll go to our website again. You'll click on providers. Click on the coverage and reimbursement link. We'll click on the coverage and reimbursement lookup tool link. It'll bring you to this page where you can enter in your code, your provider type, and the data service. Our forms are also found on our website. You can get there again by clicking on the providers tab, click on the provider's resource and information. You can click on the forms link. Provider form directory link. And here you can select from the down drop menu several of our forms that are current. So our Medicaid Information Bulletin, also known as our MEB, we encourage providers to review any and all of the MIBs that are out on our website. These are published quarterly, and they include updated provider information, and at times, special interim MIBs are published out of cycle to provide important updated information. Those can be found again on our website, and you'll go to click on our providers tab, click on the provider resources and information link. You'll click on the Medicaid Information Bulletins. Again, click the link that comes up. Click the Medicaid Information Bulletins. And this will, you can pick from our non-traditional Medicaid program, the PCN or Primary Care Network, which is no longer being used, and then our traditional Medicaid program. So the Utah Medicaid Provider Training Center contains on-demand videos that offer instruction and training for providers on varied subjects. Current topics include nursing home UPL QI compliance form training, nursing home BCRP resources training, nursing home quality improvement incentive 1 training, telemedicine policy training, and capital improvement incentive training for ICF and IID facilities. And you'll want to check back frequently for new content at the website medicaid.utah.gov/training-videos. Next, we're going to take a look at our patient eligibility lookup tool that can be found at our website again at medicaid.utah.gov. Medicaid.utah.gov. In order to access this, you will need a Utah ID, but you'll click on our providers tab again and click on patient eligibility verification. It'll bring up this page. There are 3 ways that you can sign up for a a Utah ID, and those are in purple. You can click the Register Now link. Don't have a login, Register Now, and again below Register Now. If you do have that, you can use your login information. It'll bring you to this page. To submit an eligibility inquiry on a specific member, you'll enter your provider ID, the data service, and a combination of the following search criteria. So 1 value from the unique identifiers column and 2 values from the demographics column, or all 3 values from the demographics column. Only exact matches will return results. So if anything is off, it will not bring up anything over. So we're going to look at what a fee-for-service network member looks like, and those claims should be billed to Utah Medicaid. So this is what a fee-for-service member's eligibility looks like in the lookup tool. As you can see, the member benefit type is traditional, and gives you the service date that the eligibility was checked. It will also have the demographics information. And you can see that the eligibility date span, or in the coverage information, they have the eligibility date span. Again, tells you what benefit type they have. If they have any copay information, what eligible services they have, what health plan they have, dental plan, mental health provider, and SUD provider. There's also, if you can look, there's the show coverage calendar in the left-hand corner. That's a pretty neat tool to have, and that's on this slide. It shows you what coverage they had for the months from January to May that this patient had traditional. If there's any changes in coverage coverage information eligibility, it would be shown here. So a Medicaid member is required to present the Medicaid card before each service. Providers must verify each member's eligibility every visit before rendering services. Presentation of the Medicaid member card does not guarantee a member is eligible for Medicaid. You'll want to verify the member's eligibility, determine whether the member is enrolled in a managed care plan, an EOP program, or the emergency only program, or the restriction program. Are they assigned to a primary care provider? Or are they covered by a third party, or responsible for a copayment or co-insurance? Eligibility and health plan enrollment may change from month to month. You'll want to retain the documentation of the verified eligibility for billing purposes. And to verify member eligibility, you can use Access Now, the eligibility lookup tool, or you can check your ANSI 270 and 271 reports. The member cost sharing. Cost sharing in the Medicaid program can include co-insurance, co-payment, deductibles, and premiums. Some Medicaid members share the cost for certain services, including prescription drugs, inpatient hospital services, and non-emergent use of emergency department services. The Utah Medicaid State Plan changed updated cost sharing amounts to align with the requirements found in 42 CFR 447.50, sections 1902A 14, 1916, and 1916A of the Act. The cost sharing amounts are as follows: $8 for each non-emergency use of the emergency department, $75 for each inpatient hospital stay, episode of care, $4 for each outpatient service visit, which include urgent care, physician visit, podiatry visit, physical therapy, etc. $4 for each outpatient hospital service visit, maximum of 1 per person per hospital per date of service. $4 for each prescription. $1 for each chiropractic visit, a maximum of 1 per day of service, and $3 for each pair of eyeglasses. Some services are exempt from a copay. So even if a member ordinarily has a copayment, do not collect a copayment for the following services. They are family planning, preventive services, including vaccinations and health education, pregnancy-related, including tobacco cessation, emergency services, provider preventable conditions, also known as PPC services, and outpatient behavioral health services. We do want to note that non-emergent use of an emergency room requires a copay. So the out-of-pocket cost exemptions. So the following groups and services are exempt from out-of-pocket costs. So under the group category, there are children under the age of 19, any individual whose medical assistance for services are furnished in an institution, American Indian and Alaskan Native individuals, individuals receiving hospice care, individuals whose total gross income before exclusions and deductions is below the temporary assistance to needy families or the TANF standard payment allowance, QMBs or qualified Medicare beneficiaries, individuals who are enrolled in Medicaid under the breast and cervical cancer treatment program. The services that are exempt are emergency services. That is an emergency use of an emergency room. Family planning services, including contraceptives and pharmaceuticals, pregnancy-related services, including tobacco cessation, preventive services, including vaccinations and health education, and provider preventable condition or PPC services. Okay, and with that, we'll turn the time over to Tiffany.
Thank you, Cindy. Let's talk about member responsibilities. A Medicaid member is responsible for certain costs, including charges incurred during a time of ineligibility, charges for non-covered services, including services received in excess of Medicaid benefit limitations, charges for services which the member has chosen to receive and agreed in writing to pay as a private pay member, spend down liability, and cost-sharing amounts such as premiums, deductibles, co-insurance, or co-payments imposed by the Medicaid program. Billing Medicaid members. Payment made by Medicaid for a service is considered payment in full. Once the payment is made to the provider for covered services, no additional reimbursement can be requested from the member. Medicaid members may be billed for co-payments and co-insurance. Medicaid members may only be billed for broken appointments if the provider has a policy in place to bill for broken appointments that applies to all patients, not just Medicaid members, and the member has signed an agreement to pay for broken appointments. Charges for services which the member has chosen to receive and agreed in writing to pay as a private pay member. A traditional and non-traditional Medicaid member may be billed for non-covered services when all four of the conditions below are met. The provider has an established policy for billing all patients for services not covered by a third party. The member is advised prior to receiving a non-covered service. The member agrees to be personally responsible for the payment. That agreement is in writing between the provider and the member, which details the service and the amount to be paid by the member. For complete information regarding billing Medicaid members, see Utah Medicaid Provider Manual, Section 1, Chapter 7. Right here, you'll see a sample of financial agreement form. These are available on our website under medicaid.utah.gov/Utah-Medicaid-forms. Billing for emergency services provided to a non-citizen. The Emergency Services Program for non-citizens has a very restricted scope of services and does not have some of the same restrictions on billing the individual, as is the case with other Medicaid covered services. If a provider does not receive payment from Medicaid because the provider failed to follow procedure to get a service covered, the provider is prohibited from pursuing payment from the individual. However, if payment is not made because the service was not an emergency or the service is not covered under the program, then the individual can be billed for those services. If a service is a covered service and meets the Medicaid definition of emergency, Medicaid will pay for the service. That is subject to correct coding. However, if a non-citizen eligible for emergency services only presents at the emergency department with symptoms that do not appear to be emergent in nature, the provider would be prudent to inform the individual prior to the service that the service might not be covered by Medicaid. In this case, the individual will be financially responsible for paying the bill. Charges that are not the responsibility of the member. Except for the cost-sharing responsibilities discussed previously, members are not responsible for the following charges. A claim or portion of a claim that is denied for lack of medical necessity. For exceptions, please refer to Chapter 3, Provider Participation and Requirements, Exceptions to Prohibition on Billing Members, charges in excess of Medicaid maximum allowable rate, a claim or portion of a claim denied due to provider error, a service for which the provider did not seek prior authorization or did not follow up on a request for additional documentation, a claim or portion of a claim denied due to changes made in state or federal mandates after services were performed. The difference between the Medicaid cost-sharing responsibility, if any, and the Medicare or Medicare Advantage copayments. Charges that are not the responsibility of the member. Medicaid pays the difference, if any, between the Medicaid maximum allowable fee and the total of all payments previously received by the provider for the same service by a responsible third party. Members are not responsible for deductibles, co-payments, or co-insurance amounts if such payments, when added to the amounts paid by third parties, equal or exceed the Medicaid maximum for that service, even if Medicaid amount is zero. The member is not responsible for private insurance cost share amounts if the claim is for a Medicaid covered service by a Medicaid enrolled provider who accepted the member as a Medicaid member. Medicaid pays the difference between the amount paid by private insurance and the Medicaid maximum allowed amount. Medicaid will not make any payment if the amount received from the third-party insurance is equal to or greater than the Medicaid allowable rate. Coordination of benefits. Before submitting a claim to Medicaid, a provider must submit and secure payment from all other liable parties, such as Medicare Part A and B. For more information, refer to the Medicaid General Information, Section 1, Chapter 11 Manual. Claims denied from Medicare as non-covered services should be submitted to Medicaid Fee-for-Service, not to the crossover mailbox. If the primary payer made line level payments on the claim, please report line level data in addition to the claim level data to Medicaid. Medicaid is the payer of last resort. Reimbursement for crossover claims or other TPL will be limited to the Medicaid fee schedule for all types of service, including FQHC and Indian Health Services. The Medicaid Fee-for-Service electronic mailbox payer ID is HT followed by 5 consecutive zeros, 4-001. The Utah Medicaid crossovers not when Medicare denies as non-covered electronic mailbox payer ID is HT followed by 5 consecutive zeros, 4-005. Corresponding EOBs for zero pay from Medicare go to fax number 801-323-1584, not to ORS. Corresponding EOBs for zero pay for other than Medicare goes to ORS fax 801-536-8513. Interpretive services. First, determine if member is eligible for healthcare service. Verify the member is eligible for a federal or state medical assistance program. Programs include Medicaid, CHIP, and/or services authorized on a state medical services reimbursement agreement form, also known as an MI-706. To verify member eligibility, use the eligibility lookup tool on our website or call Medicaid information to access Now at 801-538-6155 or 1-800-662-9651 or the ANSI and ANSI 276 reports. Second, if not eligible, the member is not eligible for interpretive services. Third, determine if member is in managed care. Is the member enrolled in an ACO, prepaid mental health plan, and/or dental plan? For yes, we'll move on to step 4. For no, member is not enrolled in a plan, we'll go to step 5 because the member is fee for service. So step 4, service covered by an ACO, prepaid mental health plan, and/or dental plan. If yes, the ACO, prepaid mental health plan, and dental plans must also cover the interpretive services. Contact the plan directly for more information. Step 5, service covered by fee-for-service medical program for which the member is eligible. To determine CPT coverage, refer to the online coverage and reimbursement lookup tool available on the Medicaid website. Yes, the service is covered. Interpretive service is also covered. No, the service is not covered. The member does not qualify for interpretive service. And finally, step 6, when both the member and service qualify, call one of the contractors listed in the general attachment section under interpretive guide on our website. Give the required information below. You'll need the member's first and last name spelled exactly as it is on the Medicaid member card, the member's date of birth, 6 digits only, 2 digits for the month, 2 digits for the day, and 2 digits for the year, member's Medicaid ID number, your NPI number, and the language you are requesting. Telehealth policy information. Telehealth policy information is found in the Utah Medicaid Provider Manual, Section 1, General Information, Chapter 8-4.2 Telehealth, and R414-42 Telehealth, which provide information related to coverage and limitations of this service. Utah Medicaid covers medically necessary, non-experimental, and cost-effective services provided via telehealth. There are no geographic restrictions for telehealth services. Telehealth communications may occur through interactive audio or video transmission. Services can be provided between a member and a distant site provider when a member is in their home or other location of their choice. Additionally, the distant site provider may participate in the telehealth interaction from any appropriate location. Telepsychiatric consultations. Telepsychiatric consultations, as described in Utah Code 26-18-13.5, between a physician and a board-certified psychiatrist are a covered service. Psychiatrists should report the following time-based CPT codes. 99446 is the interprofessional telephone internet assessment and management service provided by a consultative physician, including a verbal and written report to the patient's treating, requesting physician or other qualified healthcare professional. This is for 5 to 10 minutes of medical consultative discussion and review. CPT 99447 is for 11 to 20 minutes. CPT 99448 for 21 to 30 minutes, and CPT 99449 for 31 minutes or more. The requesting physician should report CPT code 99358. This service will be covered by all physical health managed care entities or MCEs. If a member receiving this service is part of an MCE, then the provider must be enrolled with the member's MCE in order to receive reimbursement. Dentistry. Teledentistry services are covered for eligible members statewide. Providers must bill the appropriate teledentistry code, D9995, teledentistry synchronous, on a line in addition to one of the 3 associated dental codes below. The D0140 for the limited oral evaluation, the problem focused, D0170, the re-evaluation, limited problem focused for an established patient, not post-operative visit. D0171, reevaluation. This is for the post-operative office visit. The teledentistry code will be reimbursed at $0 and will be used for tracking purposes only. Rates for approved teledentistry services are the same as rates for the in-person dental services. Telehealth billing requirements. Refer to the following when billing for services provided via telehealth. For distant provider, CMS 1500 professional claims, provider must indicate the service or services were provided via telehealth by indicating place of service 02 on the CMS 1500 claim form with the service's usual billing codes. For a UB04 on institutional claims, providers must indicate that the service or services were provided via telehealth by appending the GT via interactive audio and video telecommunication systems modifier to the UB04 institutional claim form with the service's usual billing codes. Services provided via telehealth have the same service thresholds, authorization requirements, and reimbursement rates as services delivered via face-to-face. The EOP dialysis program can be found in our general attachment section of our manuals, and you will see right here we've got it circled, the EOP dialysis coverage instructions, which we'll talk about in the next slide. Emergency Services Program for Non-Citizens Dialysis Program. Individuals who are eligible for the Emergency Services Program for Non-Citizens, otherwise known as the Emergency Only Program, or EOP, may now receive outpatient hemodialysis services when they meet financial and clinical eligibility. They must be eligible for the EOP program, be diagnosed with end-stage renal disease, ESRD, have a qualifying emergency department event. In order to determine the individual's eligibility for this service, providers must follow the instructions given in the EOP dialysis coverage 2-20 information sheet found under all providers' general attachments, which you saw in the previous slide. For the EOP dialysis program, you'll want to check the patient eligibility using our website under the providers section. You want to select the patient's eligibility verification. Billing a managed care entity. Medicaid contracts with managed care entities, also known as MCEs, to deliver medical, dental, mental health, and substance use disorder, also known as SUD services, to Medicaid members. Medicaid members may have fee-for-service Medicaid or an MCE depending on where they reside. Members may have a combination of fee-for-service Medicaid and MCE enrollment for different programs and benefits. Providers are responsible for verifying Medicaid eligibility and determining if a member is enrolled with an MCE before rendering services. Providers can verify a member's Medicaid eligibility by using the eligibility lookup tool located on our website. A provider who accepts Medicaid agrees to accept MCE payment as payment in full. This includes any deductible, coinsurance, or copayment owed by the Medicaid member. Medical and dental services received from an Indian healthcare provider will continue to be billed directly to fee-for-service Medicaid, regardless of the member's MCE plan. Billing an accountable care organization. If a Medicaid member received a physical health service and is enrolled with an ACO, send the claim to the accountable care organization, also known as ACO. An ACO contracts with Medicaid to pay for physical health services provided to Medicaid members enrolled with the ACO. Currently, over 80% of Medicaid members receive their physical health benefit from an ACO. In order to provide services to members enrolled in an ACO, providers must contract directly with a specific ACO plan where the member is enrolled. When required, providers must obtain prior authorization directly from the ACO plan. Utah Medicaid's ACOs include Health Choice, Healthy U, Molina, and Select Health. Enrollment in an ACO is mandatory in Box Elder, Cache, Davis, Iron, Morgan, Rich, Salt Lake, Summit, Tooele, Utah, Wasatch, Washington, and Weber counties. Enrollment in an ACO for Medicaid members in other counties is voluntary. ACOs are required to cover the same services that Medicaid fee-for-service network covers. Billing an integrated care plan. Utah Medicaid Integrated Care, also known as UMIC plans, contract with Medicaid to manage the behavioral and physical health benefit. Only adult expansion Medicaid members are enrolled in UMIC plans. Bill the UMIC plan that the patient is enrolled in for behavioral and physical health services. UMIC plans are only in Weber, Davis, Salt Lake, Utah, and Washington counties. UMIC plans are managed by Health Choice, Healthy U, Molina, and Select Health. In order to provide services to members enrolled in a UMIC plan, providers must contract directly with the UMIC plan in which the member is enrolled. When required, providers must obtain prior authorization directly from the UMIC plan. Healthy U is not available in Washington County. Enrollment in a UMIC plan is mandatory for adult expansion Medicaid members in Weber, Davis, Salt Lake, Utah, and Washington counties. UMIC plans cover the same services that the Medicaid fee-for-service network covers. Billing a dental plan. Utah Medicaid contracts with 2 managed care plans statewide to deliver dental services provided to Medicaid members. Utah Medicaid's dental plans include Premier Access and MCNA Dental. The following members who are eligible for full dental services are required to be enrolled in a dental plan. Members who are age 0 to 20 and eligible for EPSDT, members who are pregnant, and members who qualify for Medicaid due to a disability or blindness. In order to provide services to members enrolled in a dental plan, providers must be contracted with the dental plan listed for the member on the eligibility lookup tool. Dental services received from an Indian healthcare provider will be billed directly to fee-for-service Medicaid, regardless of the member's dental plan. The dental plans cover all services that the Medicaid fee-for-service network covers, except the following carved-out services. General anesthesia performed at a hospital or ambulatory surgical center. Medical and surgical services of a dentist performed at a hospital or ambulatory surgical center. Craniofacial anomalies and cleft lip or palate surgeries. The dental plans may have their own utilization requirements for covered benefits. For example, they can require authorization or request documentation be submitted with a claim even if fee-for-service does not have the same requirements. Providers should refer to the dental plan provider manual for utilization and PA requirements. If a service requires a PA, the provider must obtain the PA from the member's dental plan listed on the eligibility lookup tool. Adults who are eligible for Medicaid due to a disability or visual impairment and who want to receive services through the University of Utah School of Dentistry may do so regardless of the dental plan they are enrolled in. The University of Utah will bill fee-for-service for these services. For more information regarding U of U School of Dentistry services and locations, call 801-587-6453. Coverage for dental crowns through the dental plan. For stainless steel crowns, dental plans cover stainless steel crowns for all of their enrolled members. Please visit the dental plan website or contact the dental plan for information on their authorization requirements for stainless steel crowns. Porcelain crowns and porcelain fused to metal crowns. For pregnant women and children covered under EPSDT, porcelain crowns and porcelain fused crowns are only covered under a spend-up agreement between the provider and member. Adults 65 plus who are on Medicaid due to a disability or blindness can have a porcelain crown or porcelain fused to metal crown covered through the University of Utah Provider School of Dentistry network. If they choose to use a provider that is not enrolled with the School of Dentistry, they can only have the crown covered by the dental plan under a dental spend-up agreement with their dental provider. Coverage for teledentistry services through a dental plan. As of March 1st, 2020, synchronous teledentistry services are covered by the dental plans. The teledentistry code D9995 must be billed in conjunction with D0140, D0170, and D0171. Billing a prepaid mental health plan. Under the prepaid mental health plan, also known as PMHP, Medicaid contracts with local county mental health and substance abuse authorities to provide mental health and substance use disorder services to Medicaid members. Prior to delivering services, providers must verify the member's PMHP through the Medicaid eligibility lookup tool. If a Medicaid member is enrolled in the PMHP, the provider must either refer the member to his or her PMHP for services or ask the PMHP for authorization before providing services. Otherwise, the PMHP might not pay the provider. All Medicaid members enrolled in the PMHP may also get their services directly from a federally qualified health center, also known as an FQHC. PMHP authorization is not required. American Indian and Alaska Native Medicaid members may get their services directly from the Indian Health Services, also known as IHS, or a tribal or urban Indian organization UIO facility. PMHP authorization is not required. Medicaid members with subsidy adoption Medicaid may be disenrolled from their PMHP on a case-by-case basis for outpatient mental health and outpatient SUD services. They remain enrolled in the PMHP for inpatient psychiatric hospital care. FQHC and RHC. Federally Qualified Health Center, also known as FQHC, and Rural Health Center, also known as RHC, have two options for payment. The first, 100% billed charges, all edits do apply, and the second, by encounter. Must bill T1015, must bill all CPT codes that apply, and at least one CPT code must be an approved encounter code. If only the T1015 or only the CPT codes are billed, the claim will be denied. Void and replacement claims. Providers should submit their own corrections to claims less than 3 years old by submitting their either a replacement or void claim. The data elements needed to identify a replacement or void claim are the claim frequency code, 7 for replacement, 8 for void, electronic X12 element 2300, CLM 05-3 for paper on a UB04, form locator 4 position, and the CMS 1500, box 22 is where you'd put the code. You'll also need the transaction control number, also known as a TCN, of original claim to be replaced or voided. Electronically, X12 element 2300 REF02. For paper on a UB04, it's the form locator 37A-C. And a CMS 1500, it is box number 22 for the original transaction control number. Payment adjustment, an overpayment or credit balance. An electronic payment adjustment request form for fee-for-service is available for issues regarding overpayments and credit balance on claims more than 3 years old. If a payment adjustment is required on a claim that is less than 3 years old, a replacement claim must be submitted. The form is located on our website under our forms section. The form may be filled out online before printing. One form is required per claim. All required fields must be appropriately filled out, or it will be returned to the provider. The payment adjustment request form for checks for Medicaid operations related to credit balance, third-party liability for crossover claim payments, or overpayments older than 3 years can be mailed to Bureau of Medicaid Operations, Payment Adjustments, P.O. Box 143106, Salt Lake City, Utah 84114-3106. And checks for third-party liability payments, TPL, excluding crossover claim adjustments, can be mailed to Office of Recovery Services, Medicaid Section Team 85, P.O. Box 45025, Salt Lake City, Utah 84145-5025. Timely filing. All claims and adjustments for services must be received by Medicaid within 12 months from the date of service. New claims received past the 12-month filing deadline will be denied. Any corrections to a claim must also be received and/or adjusted within the same 12-month time frame. If a correction is received after the deadline, no additional funds will be reimbursed. In the case of Medicare crossovers, all claims and adjustments must be received within 6 months of the Medicare decision. The 12-month timely filing period is determined from the date of service or from date on the claim. The exception to this is for institutional claims that include a date of service span. An example, a different from and through date on the claim. The through date of service on the claim is used to determine the timely filing for institutional claims. For additional information, please see 42 CFR 447.45. Grievances, appeals, and hearings. States are required to have a fair hearing system that complies with the provisions of 42 CFR 431 subpart E. The department's administrative hearing procedures are described in Utah Administrative Code R 410-14. A provider can request a hearing to challenge an action. An action is defined as a denial, termination, suspension, or reduction of medical assistance for a recipient. a reduction, denial, or revocation of reimbursement for services for a provider, a denial or termination of eligibility for participation as a provider, a determination by skilled nursing facilities and nursing facilities to transfer or discharge residents, an adverse determination, meaning a determination made that the individual does not require the level of services provided by a nursing facility, or that the individual does not require specialized services. And last, an adverse benefit determination made by an MCE, which we'll review in the next slide. The purpose of the fair hearing will be to determine whether the action taken was in accordance with Medicaid policy. Requests for a hearing, other than those challenging an adverse benefit determination made by an MCE, must be filed within 30 calendar days of the date the department sent the provider notice of its intended action. Requests for hearing forms can be found on the department's website. MCEs are required by federal regulations to have a grievance and appeals system. Appeals of adverse benefit determinations. An appeal is a review by an MCE of an adverse benefit determination, also known as an ABD. ABDs include but are not limited to MCEs denying payment in whole or part, denying or limiting authorization of a requested service, etc. If an MCE makes an ABD, the MCE must send notice of the ABD explaining how to request an appeal to the ABD. An appeal request must be filed with the MCE within 60 calendar days from the date on the notice of the ABD. If the MCE's appeal decision is adverse, a state fair hearing with the Medicaid agency may be requested. A hearing must be requested within 120 calendar days from the date of the MCE's notice of ABD resolution. Grievances. A grievance is an expression of dissatisfaction about any matter other than an ABD. Grievances may include, but are not limited to, the quality of care or services provided by the MCE, rudeness of MCE providers or employees, and failure to respect Medicaid members' rights, etc. Grievances may be filed with the MCE at any time. MCEs must address the grievance within 90 calendar days from the date the MCE receives the grievance. Electronic visit verification, also known as EVV. EVV requirements defined in Section 12006 of the 21st Century's Cures Act were effective for Utah Medicaid beginning July 1st, 2019. EVV requirements apply to all personal care services and home health care services provided under state plan or 1950C home and community-based waiver. The effective date is for both personal care services and home health services. However, this allowance for claims with incomplete records did not occur until January 1st, 2020 for personal care services and will occur January 1st, 2023 for home health care services. Choice of reporting systems for EVV are by provider preference, but must meet all federal requirements, including the standards set in the Health Insurance Portability Accountability Act. The state will not implement a mandatory model for use. All provider choice EVV systems must be compliant with requirement of the Cures Act, including 1, type of service performed, 2, individual receiving the service, 3, date of the service, 4, location of service delivery, 5, individual providing the service, and 6, time the service begins and ends. For inquiries, feedback, and questions regarding electronic visit verification, email dmhf_EVV@utah.gov. Record keeping. The Utah Department of Health Division of Medicaid and Health Financing follows the provisions of the Government Records Access and Management Act, also known as GRAMA, in classifying records and releasing information. Medicaid providers must comply with all disclosure requirements in 42 CFR 455 subpart B, such as those concerning practice ownership and control, business transactions, and persons convicted of fraud or other crimes. Every provider must comply with the following rules regarding records noted in Section 1, General Information, Chapter 4 on the Utah Medicaid website under the Section 1 manual. And with that, I will give the time back to Cindy.
Thank you, Tiffany. Again, if you do have questions about any of the slides that we've gone over this afternoon, you can reach out to the appropriate department. And we'll go ahead and turn the time over to our prior authorization team.
Thank you, Cindy. Hello, everyone. My name is Annette Wynn. I am one of the supervisors on the prior authorization team for Medicaid. I want to thank you all for listening to the statewide provider training. Today, I will be sharing some important information about the prior authorization process, which should make your jobs easier. The medical prior authorization team is part of the Bureau of Healthcare Policy and Authorization. It is the PA team's job to review the requests and clinical documentation sent in by the providers to determine whether the services being asked for meet medical criteria and the established policy. The team will then send back a response to the requesting provider. This diagram shows how the medical prior authorization process works and the steps that are taken. Ultimately, there are 3 outcomes: approved, denied, or returned for more information. The Medicaid website has a lot of useful information for providers. Prior authorization is located under healthcare providers. This section contains everything you need in order to complete and submit a prior authorization. All necessary forms are located in this section. This includes forms for pharmacy, resident assessment, as well as all general PA forms. Most of the forms needed in order to complete a prior authorization request will be under the general PA forms section. PA in alphabetical order. We currently have 8 prior authorization request forms. This page is where all other forms are located. Some of these forms include consent forms, acuity grids, the wheelchair evaluation forms, etc. Please make sure to get the forms off the website each time you need one to make sure you are using the most current form. When filling out a PA request form, please make sure you use the correct form for the services being requested. If there is not a form specific to your service, use the general PA request form. Also use the most updated version. All of the PA forms are now typable. There are certain fields on the form that are required. These fields are marked with asterisks. Please make sure to fill out these sections or the request will be returned to you as being incomplete. Please use the correct spaces provided on the forms. For example, if there are more than 3 requested codes when using the general PA form, the additional codes need to be placed on the second page of the form. Do not try to squeeze 6 codes on the first page. Please make sure you are faxing the request to the correct fax number. These PA forms are only to be used for fee-for-service Medicaid members, unless it is for a carve-out service. We will have examples of filled out prior authorization forms on the Medicaid website soon. If you would like examples before they are available on the website, please send an email to medicaidcriteria@utah.gov and specify what type of form you would like sent to you. This slide contains additional helpful tips when requesting a prior authorization. The first 2 tips are also included on the PA request form. Please make sure to verify these 2 areas when filling out the form. I'm sure all of you providers are wondering what happens to your request once you have sent it in. Like I said before, there are 3 main outcomes for a prior authorization request. It is either approved, returned, or denied. when a prior authorization request is approved, you will receive an approval fax from the PA reviewer, which will include the approval screen. A request may be returned by a screener for data entry issues or for clinical reasons by a clinical reviewer. A request may also be denied. We do have an internal status of pended that is just a temporary status. This status will be used by the screener once a request is complete and waiting for a clinical reviewer. Pended is also used when a request has been referred for a higher level review, such as being sent to a physician for secondary medical review or to a committee. A lot of providers wonder if prior authorization would be given after a service is rendered. There are a few limited circumstances. If the client has retroactive Medicaid eligibility, if the medical supplies were provided in a medical emergency, and if the services provided were due to a medical emergency. All retroactive authorizations must be requested within 90 days of the client either becoming eligible for Medicaid or within 90 days of the medical emergency. There are some surgical and anesthesia exceptions, and they must also be requested within 90 days of the original procedure. You will need to complete the PA request form as usual, but make sure to mark that it is a retroactive request and write in the reason why the service was provided without prior authorization. Make sure to include all required medical documentation, such as an op report for a surgery, an MRI report for an imaging, and then you also want to fax the complete request to the appropriate fax number. Please refer to the Section 1 General Information Medicaid Manual for complete details on retroactive requests. Where can I find criteria? Required criteria may be found in a few different areas on the website. From this page, you can click on Medicaid criteria and or the different provider manuals. We also use Interqual, which is a web-based criteria system for several of the programs. What's new in prior authorization? Several things are new in prior authorization this year. We are currently in the process of updating our PA request forms. There will be a new urgent request option on the updated form. We are also in the process of creating new PA request forms. There will be a new form for the DME program. We are in the process of updating Interqual criteria and the provider manuals. There have been updated PA requirements, so please check the coverage and reimbursement lookup tool for the PA requirements. I also highly encourage everyone to use the resources on our Medicaid website. There is a lot of information on there that is very helpful. We also have new staffing in the prior authorization department. Our newest team is our screen team, and that has made a new method for how prior authorization requests are processed. This slide contains some PA data for both medical and pharmacy prior authorizations. This information gives you a small glimpse of the work we do. For medical PA, we process an average of 2,700 prior authorizations per month. We receive approximately 1,000 phone calls per month. 35 to 40% of the requests are returned on the initial request. And we are trying to decrease the issue of these returns with statewide provider training like today, and also by giving individual providers extra training if needed. We utilize data to drive decision-making. So some of the data collecting helps us determine appropriate staffing, determine if PA is needed for certain services, and also it gives us the length of time that reviews take in order to be processed. For pharmacy, they process an average of 1,445 prior authorizations per month. They receive an average of 621 phone calls per month, and they also utilize data to drive decision making. There are a lot of frequently asked questions, and most of these questions are answered on the Medicaid website. But if you have additional questions that need to be answered, you may email them to medicaidcriteria@utah.gov. In case you have any questions, the next slide has been included for guidance. This slide contains email addresses and phone numbers of where questions may be sent. Thank you for letting me share all of this important information with you, and I will now turn the presentation back to Cindy.
Thank you, Annette. All right, and we'll go ahead and get started with our Medicaid pharmacy program.
Hi, my name is Dana Boy, and I'm a certified pharmacy technician. Today, I'll be going over the Medicaid pharmacy program with you. We are part of the Bureau of Healthcare Policy and Authorization. Our team manages the pharmacy benefit for fee-for-service Medicaid members to ensure the safe, appropriate, and cost-efficient use of medications. We have an awesome team consisting of clinical pharmacists, pharmacy technicians, and clinical consultants. Functions: determining the pharmacy program coverage, reviewing prior authorizations, creating pharmacy policy in conjunction with DUR, which is a drug utilization review, and PNT, pharmacy and therapeutics committees, interacting with pharmacy providers, prescribers, and members, and also coordinating with other Medicaid bureaus. Did you know that the pharmacy services are a covered benefit for Medicaid members, but it is optional? Keep in mind that the emergency Medicaid members for non-citizens do not have pharmacy benefits. Outpatient drugs included in contracts with the Accountable Care Organization, or ACO, must be obtained through the ACO for their members. Carved out services will be through the fee-for-service benefit. And for a full list of what those carved out services are, you can visit the Medicaid Pharmacy Manual. We have a new and improved preferred drug list, or PDL. It's been consolidated in the resource library. So there's the PDL criteria limits document, brand over generic list, over-the-counter drug list, mandatory 3-month supply list, and prior authorization forms. All of those used to be in separate attachments or documents, but now they're all in one document, hoping that that would be more beneficial and helpful to all of you. Now, going over some basic definitions of PDL versus formulary. A formulary lists what is covered and not covered. PDL is more inclusive, lists covered products that are either preferred or non-preferred. Our covered products need to be trialed first, may or may not require prior authorization. So for example, under the hepatitis C drug class, the preferred drugs are the brand Epclusa and Mavorette. However, they will require a prior auth. And then our non-preferred are covered products that requires a prior authorization. We also manage the Medicaid information bulletins, MIBs, and pharmacy manual quarterly. The fax blast, we just ask that the providers keep their information updated, such as phone, fax, etc. We manage the Utah Administrative Code R414-60 Medicaid Policy for Pharmacy Program, R414-60A DUR, and R414-60B PDL. And this is our pharmacy program website. We have a section for preferred drug list, PNT committee, prior authorization, Drug Regimen Review Center, Drug Utilization Review Board, and Resource Library. So going over some pharmacy prior authorization information, all of our forms are located at medicaid.utah.gov/pharmacy/prior-authorization. We have a 24-hour turnaround time within normal business hours in accordance with the Utah Code 26-18-105. There's a 72-hour override that's available when there's a medical emergency that occurs for a medication that requires a PA. The provider may dispense up to a 72-hour supply of the medication without obtaining a prior authorization. We just ask that the pharmacist makes their best judgment of what that medical emergency is and enter the appropriate overrides. The overrides are also listed under the PA Forms website. Retroactive prior authorization is not permitted except in cases of retroactive Medicaid eligibility. And for more details about that, you can refer to the Utah Medicaid Provider Manual, General Information Section 1. We've had a ton of pharmacy services updates we'd like to share with all of you. Prior authorization services actually started with us in May 2019. Peer-to-peer outreaches are to support improved clinical outcomes. Mandatory 3-month supply applies to all maintenance medications. HCPCS billing versus retail refer to the lookup tool. 340B billing, correct point of sale or POS billing is in our pharmacy manual. The hemophilia sole contract with the University of Utah ended 12/31/19. We've made changes to the SPA and rule. The case management services started 1/1/2020. We have a hepatitis C adherence program that started 4/1/2020 in efforts to increase the adherence rate. Program integrity work is ongoing. Breast and cervical cancer cost sharing waived. Maximum acquisition cost, MAC pricing contract started 5/1/2020. And we have had comprehensive opioid policies to align with the SUPPORT Act. Back in January 2019, we would start off with morphine milligram equivalents or MME limit at 180, and we would decrease that over a period of time. The 180 got reduced to 150, 150 to 120, and effective 7/1/2020, the 120 MME went down to 90 MME. And this is exempted in members with an active cancer diagnosis of G89.3. Concomitant opioids and benzodiazepines. Effective 7/1/2019, no concurrent use of long-acting opioid and benzodiazepines are allowed. And effective 10/1/2019, at the pharmacy point of sale, there will be a DOR override flag that will hit for short-acting opioids and benzodiazepines, and the pharmacy will have to enter the appropriate codes for their appropriate interventions to have a paid claim. And then the Drug Utilization Review Board reviewed safety and misuse abuse potential of gabapentin and pregabalin during the January 2020 meeting to promote best practice and safety standards that align with the Food and Drug Administration labeling. We've set up some daily dose limits for gabapentin and pregabalin effective 4/1/2020. Gabapentin has a limit of 3,600 milligrams per day and pregabalin 600 milligrams per day. In addition, concurrent use of gabapentin and pregabalin is not permitted. Opioids in children, effective 7/1/2019, no more than a 7-day supply of opioids in children are allowed. Opioids in pregnancy, effective 10/1/2019, also the same thing, no more than a 7-day supply of opioids in pregnancy. Our refill tolerance was updated to 85% for all controlled substances effective 4/1/2020. Antipsychotics in children. We have set some dose limits for children under 20 years of age. A prior authorization is required for use in very young children younger than 6 years of age. A diagnosis code is required on all initial antipsychotic prescriptions, and a prior auth is required for concurrent use with other antipsychotics. Attention Deficit Hyperactivity Disorder, or ADHD, effective July 1st, 2020, quantity limits that align with FDA-approved pharmaceutical package insert or approved compendia. A prior authorization is required for concurrent use of amphetamine drug class with methylphenidate drug class, use of 3 or more stimulants, and stimulant use for patients under the age of 4. Reimbursement methodology. All of this information can also be found in our Utah State Plan. Covered outpatient drugs will be reimbursed based on the established product cost plus professional dispensing fee. The payment for individual prescriptions shall not exceed the amount billed. The amount billed must be no more than the usual and customary charge UNC to the private pay patient. The lesser of methodology is used to establish Medicaid payments. The lesser of logic is the reimbursement for brand and generic covered outpatient drugs as follows: the lesser of the Utah estimated acquisition cost, federal upper limit, national average drug acquisition cost, Utah maximum allowable cost, or the ingredient cost submitted. The Utah Medicaid professional dispensing fees are as follows: $9.99 for urban pharmacies located in Utah, $10.15 for rural pharmacies located in Utah, $9.99 for pharmacies located in any state other than Utah, and $716.54 for hemophilia clotting factor. Urban pharmacies are pharmacies physically located in Weber, Davis, Utah, and Salt Lake counties. We allow 1 dispensing fee per 24 days per covered outpatient drug per pharmacy. Now, the next 4 scenarios we're going to go through are what the pharmacy and the providers may encounter. The first scenario is the pharmacy has a rejection for PA required on Trulicity. How do you know which product is preferred? The answer is to please refer to the preferred drug list. And keep in mind that we do have a new formatting, a new design for our PDL, but you will see that the Trulicity is listed as non-preferred under the GLP-1 agonist. And the preferred products are listed right above it under preferred drugs. You'll see Bydureon, B-Cise, Ozempic, and Victoza, which do not require a PA. Scenario number 2, the pharmacy has a rejection for PA required on quetiapine for a patient under 20 years old. What form do you fill out? The answer is to navigate to the Medicaid Pharmacy Prior Authorizations Form page online at medicaid.utah.gov. There will be a tab for providers at the top that you'll click on, and then Prior Authorization, Pharmacy Criteria Forms, and you'll notice that it will be listed in alphabetical order, either under drug or drug class. So under this specific scenario, you will not find the form under quetiapine, but instead the correct form is under antipsychotics in children. And with all prior authorizations, please fill out the form and submit updated chart notes or letter of medical necessity supporting the criteria listed on the form. And we do encourage that all of our providers Get familiarized with the PA form online, because this is where all of our forms and criteria will be updated. Scenario number 3. The diabetic testing supply you're looking for is not on the PDL. What does this mean and what do you do? The answer is the diagnostic products not listed on the PDL are non-preferred products and cannot be processed through the pharmacy benefit. So some or most of the rejections will occur first at the pharmacy, making the pharmacy or the provider think that you'll need to submit a pharmacy prior authorization form, when in fact, these products must be billed through the medical benefit as durable medical equipment, or DME. Scenario number 4. How do you know if a medication can be billed through POS or medical HCPCS billing? Answer number 1, to refer to the PDL. Note that not all HCPCS codes are included in the PDL. Number 2, refer to the coverage and reimbursement lookup tool. Enter the provider type and appropriate HCPCS code. The lookup tool will let you know whether it is billable under that specific provider type and if it will require a prior authorization. COVID-19 updates. SEC 13 is a refill to soon related to COVID-19 with all quantity limits and policy limits that apply. Copays waived for COVID-19 diagnosis codes, postage and delivery fees, $2 per claim for delivery fee and $1 per claim for postage fee. Some medications on shortage are removed off of the mandatory 3-month supply list. And for the most updated list, you can refer to the resources library. Proof of delivery requirements are waived during the COVID-19 emergency period for non-C2 prescriptions. And that is the end of the Medicaid pharmacy program. Thank you so much for your time.
Thank you, Dana. Okay, we'll go ahead and end our presentation today with OIG presentation.
Thank you so much. I'm John Slade with the Utah Office of Inspector General. I'm so glad you're watching our training online. I've got a few slides just to help understand our program and to understand more about us, and then some examples of fraud, waste, and abuse that you could be looking for. Our office looks at payments all across the state. Medicaid pays for lots of different services, county, state services, grants, as well as hospitals and foster care children and all kinds of different places that Medicaid money is used to improve healthcare for people in the state of Utah. And I wanted this slide to show kind of how broad Medicaid is and the various things that we look at to make sure Medicaid money is spent correctly. There's a kind of a continuum of fraud. There's simple errors, there's waste, there's providing services that aren't needed, kind of a continuum. The vast majority of things in Utah that we find in error are coding errors, or just simply not knowing correctly how to bill a procedure, or not knowing all of Medicaid's rules for billing. And so that's the vast majority. We do have providers that bill for services they don't provide, which is just fraud. But the majority of things we find are just simple mistakes, billing the wrong code, or putting the wrong information in on a prescription or whatnot, that just not quite understanding what the rules are. These are Utah's definitions of fraud, waste, and abuse. Fraud is an intentionally knowing, which is usually determined by repeating the same error multiple times. That starts to show the intent to, if you make a mistake once, That's one thing. If you make a mistake 2,000 times that goes to your benefit, then that's a little harder to show that you didn't understand what you're doing. Waste is just improper payments or overutilization. And then abuse can act in a lot of ways in healthcare. A lot of it's unnecessary treatments, doing too much for a patient or too little for a patient can be abuse. Most common errors we see is just not quite understanding the billing by the coding. Coding is complicated, and so it's billing for services that are not covered, billing for services that should be combined together or shouldn't be combined together. We're seeing an increase in kickbacks where, say, a lab or a MRI facility will pay a doctor a fee for each referral they get. We also are seeing a lot of recipients that are looking for borrowing an eligibility card or looking for drugs, going to multiple doctors to get the same prescription to try and get more services than what they need. Our main goal is to protect the taxpayer dollars that go into healthcare in Utah. And so we try and balance the cost. The best, most efficient way to provide healthcare is to get top quality healthcare by good providers and have those billed correctly. And so our goal is to make sure that the care is good and that it's provided in a good manner. We have a robust audit team that looks at all the processes of Medicaid. Medicaid has lots of different rules, lots of different processes to make sure that the money is flowing to the correct places. And so our audit department looks at each of these areas to make sure that the procedures and policies in place make sense and that they're followed. Our data team uses the robust Medicaid data set to look for abnormalities and to look for ways that providers are billing different than their peers, that providers are, we have providers that are billing more than 24 hours in a day of services. Things like that really stick out in our data. And so they're looking for outliers and things that, if a diabetes patient should have these types of services. And so we look for that pattern to make sure they're not billing too much or they're not missing services that are critical to that person's health care. The program integrity unit is here to work more directly with providers, to encourage compliance and to help train and support providers to understand Medicaid better and to succeed in the Medicaid program. In this training, we've learned of lots of great resources that can help providers really do a good job. They have great MIBs, they have lookup tools, all kinds of things to help make sure that you're following the rules and regulations of Medicaid. And we're here to look at records and check to see that those match what Medicaid's expectations are. These are the different areas that are required to be audited and to be reviewed in Utah. So these are federal requirements that are mandatory for us to do and to look at in each provider. Program integrity, here's kind of our standard process. We get complaints or intake or data sends us a concern. We do a real preliminary investigation just to see if all the facts are correct and if there's a concern. Then we refer the case out. If it's not in our jurisdiction, it might be a Medicare case, or it might be a case where there's abuse that needs to go to police. And then if it's our area, we do a comprehensive review, we do site visits, we look at medical reviews, we do education of the providers, and we make sure that those focused reviews, those things help move Medicaid closer to compliance. And so our goal is to help providers succeed and to train them where they're not succeeding. And we certainly notify the providers of our findings and allow them to make sure that the claims are paid back correctly and that we can help them make sure that they're paid in an appropriate manner. Our policy team helps train and review policy and to train providers in policy, but it also makes sure that the policy we use is the same policy that's on the MIB, the same policy that's on the website. So everybody's understanding Medicaid in the same way so that we can all understand and work off of the same rules so that there's no surprises at the end of the day. Our policy team also offers to come and train at seminars or conferences. So if you're looking at needing some more information about policy, Medicaid or program integrity, we're happy to come and talk to you and help you understand better all the complexities and how specifically that policy interacts with a very defined area that you're in. Current trends, obviously telehealth has exploded this year. We're seeing more and more providers use telehealth. I started using telehealth years ago, and I think I don't know that it'll ever be back to a doctor's office, except some of my doctors require it, but it's a great way to do a lot of healthcare, and it's a great benefit for providers and for patients. We have seen some providers that have thought that you don't need to document the same for telehealth as you do for an inpatient appointment, and Medicaid's guidelines are the same for telehealth as they are for inpatient, for seeing a patient face-to-face. So make sure that you're reviewing your telehealth medical records to make sure they're the same quality as any other healthcare records. We've had to really do a lot of training on records this year because our documentation just seems to have slid because people have gotten worried about other things, and so please keep up proper Medicaid medical documentation. We've seen a lot of providers cold calling patients that didn't want services to bill a telehealth service to, and we've seen a lot of COVID labs adding things onto the COVID lab to get more money, and so we've had to really cut back on and making sure they're billing only for the services requested by the patient and the ordering physician. If you see any abuse of a patient or any concerns where a patient got poor health care or they're just not getting the services they need, please give us a call, or you can go to our website and fill out a referral form. It can be confidential. You don't have to give them your name or email or anything. We're happy to help make sure that the healthcare system, we keep the criminals out of the healthcare system and only keep the good providers in healthcare. This next slide just talks about different places to report different things. If there's abuse, it's Adult Protective Services. If it's welfare fraud, workforce services. Our office is there. And then lastly, I wanted to let you have our email addresses. So if you have any questions or concerns, feel free to email any of us and we'll get back with you. Thank you so much for your time, and thank you for watching this presentation.
Again, we want to thank the providers for taking time out of your busy days to watch this webinar. If you have questions or concerns about anything in this slide, please feel free to reach out to the departments. The contact information is available on our website. Thank you again.